or whether it has occurred following appearance, it indicates following a trauma. Suppose the patient had a trauma and presents with mass there, one should consider a pancreatic mass. I mean, it could be an inflammatory mass, it could be a traumatic pseudocyst. So sometimes these masses are incidentally discovered. You are investigating for something else most of the times in a woman who has an gynec issues. So you are investigating for a cause of a pain in the abdomen. You find incidental masses in the pancreas. Most of the times are cystic neoplasms of the pancreas, like serous cystadenoma and mucinous cystadenoma. We'd also would like to know whether these masses are symptomatic or is it because of the infection or inflammatory mass. As I said, sometimes acute pancreatitis will have an inflammatory mass. It means that there is a swelling of the pancreas, the momentum is edematous, the stomach and large intestine go and adherent and their edematous form like an inflammatory mass. We call it as a pancreatic phlegmon. So sometimes a big abdominal aneurysms, which are usually rare, and they suddenly they come with a shock due to a rupture of these aneurysms. So we would also would like to know in the history, is there any change in the size of the mass? Because that's very important. If there's a sudden increase in the size of the mass, it indicates that it could be because of the infection or it could be because of the bleed into the mass. That's why suddenly there's an increase in the size of the lesion. Or if it's occurred slowly over a period of time, mostly consider that as a benign lesion. We will also would like to know whether this patient has any symptoms, GA symptoms, gastrointestinal symptoms, or hepatobiliary symptoms like pain, nausea, vomiting, and jaundice. So these are all the gastrointestinal symptoms. So these patients, GA pathology patients will have vomiting. They may have a nausea. They may have, if it is malignant, they may have a loss of weight and appetite also. Jaundice, the tumor is arising from the say bile duct or pancreas. They may have a jaundice also. If the patient has a pain, we'd like to know where exactly the situated the pain. Pain, pancreatic pain, if you take an example, it will be in the epigastric region, which radiates to the back, classical. So the patient will explain, sir, I have a pain in the upper abdomen, which radiates to the back. So that indicates it's a pancreatic pain. Whereas if there's a lesion in the stomach, so they might complain that the pain is aggravated. If there's an ulcer in the stomach, or if there's an ulcer in the duodenum, or it's a malignant mass in the stomach, they might complain, say, after taking food, I have a pain. So it indicates that there's probably a lesion in the stomach. And if there's a big mass which is arising from the wall of the stomach, patient may not have any symptoms, or they may come with an hematemesis and melena. So this kind of a history is very, very important in the mass, if the mass is in the epigastric region. We would also like to know if this patient has any pre-existing symptoms or any other diseases. For example, if the patient has pain in the abdomen and mass in the epigastric region, it could be a carcinoma head of the pancreas or carcinoma of the pancreas. So we would like to know whether the patient is a diabetic. We would like to know whether the patient is taking an alcohol. We would like to know whether the patient is a smoker. So this kind of a history is important if there is any pathology in the pancreas. So usually, most of the times, if the mass arising from the liver or a spleen or a stomach, because they are close proximity to the diaphragm, they are freely moving with the respiration. Intrinsic mobility might be there. If it is fixed to the underlying retroperitoneal structure, for example, see a carcinoma stomach, which is fixed to the pancreas, it may not move. Intrinsic mobility may not be there, and moving with respiration sometimes may not be there. Retroperitoneal masses per se, they do not move with the respiration. The visible peristalsis sometimes we see in a carcinoma of antrum, pyloric antrum, because there is an obstruction. The proximal stomach tried to overcome the obstruction. So there is a visible peristalsis which comes from left to right. So which is seen in a carcinoma of the pylorus. Whereas if you compare, if there is a small intestinal obstruction or large intestinal obstruction, the pattern of visible peristalsis is different. For example, I don't consider this in epigastric lump, but if there is a small intestine obstruction, there you will see a step ladder type of peristalsis, whereas in a large intestine, you see right to left peristalsis. So margins, if you define, you need to define always the margins of the mass. Well-defined margins, take it, well-defined margin means neoplasm. Ill-defined margins, for example, acute pancreatitis with phlegm and stomach, there is an edema in the stomach and transverse colon and momentum. So they look diffuse mass. So ill-defined mass means it's an inflammatory lesion. Well-defined margins, it means neoplasm. So defining this mass is very important, and probably sometimes we know that probably this is a neoplasm. So defining is difficult if spelling is under the costal margin. If the tumor is in the spleen, so sometimes it will be difficult. So consistency of a mass, if it is in a cystic in the epigastric region, one should consider in a hydrated cyst which are arising from the liver, and if it is, or it could be from a pseudocyst of the pancreas. The hard masses are invariably malignant masses, invariably variable consistency. Say some area it's hard, some area cystic. It's most of the time it goes in favor of malignancy. If there is an cystic swelling arising from the liver, we consider probably most of the time either it could be a simple cyst or hydrated cyst. So you might find a fluctuation, you might find a fluid thrill in these cases, and usually they are all dull to percuss. So if you consider the differential diagnosis in the epigastrium, these are all the differential diagnosis. Stomach lesions are mostly a carcinoma of stomach, or it could be a gastrointestinal stromal tumor arising from the stomach. Lymphoma, sometimes non-Hodgkin's lymphoma will have a big mass in the epigastrium. These are very rare. Commonly seen are carcinoma stomach, and next is stromal tumor. As I said, duodenal lesions are very rare. They are less palpable. If it is very big, it's palpable, it means that it's in a stromal tumor. Neuroendocrine tumor also do arise from a duodenum. So pancreas, it could be in a cystic mass, it could be in a solid mass, it could be in a benign mass, it could be in a malignant mass. For example, cystic mass is a pseudocyst of the pancreas, solid mass is a carcinoma of the pancreas, head of the pancreas or body of the pancreas. Benign cystic lesions are cystic neoplasm of the pancreas, mucinous cystadenoma, serous cystadenoma. Again, malignancy is pancreatic malignancy. Liver masses is defined as cystic masses, solid masses, traumatic sometimes, and inflammatory also. Parasitic, I'll come to it one by one. Spleen, most of the times it's in a splenomegaly. So it may extend into the epigastrium or a cystic lesion, congenital cysts, sometimes simple cysts arising from a spleen or an angiosarcoma or vascular tumors which come from which arise from the spleen are very rare. So if a mass in the epigastric region, which is hard, no movement with respiration, mobile or fixed to palpation, it indicates most of the times carcinoma of the stomach. Whereas carcinoma of the pancreas, they are hard, fixed, and doesn't move with respiration, and you cannot get above it sometimes. They may have an history of anorexia, any malignancy in the body, they will have an history of anorexia, nausea, a loss of appetite, weight loss, and a pain in the epigastric region. One should consider a malignancy. Early stages of malignancy, these patients may not have pain, but as the disease advances, they might develop a pain in the abdomen. So a patient, this is very important, a patient who presents with a palpable abdominal mass without signs or symptoms of obstruction or a bleeding probably has a mass arising from the liver, pancreas, spleen, or retroperitoneum. So here I have excluded stomach because stomach patients, they will have pain in the abdomen, they may have a nausea, they may have a vomiting, they may have a GI bleed, they may have an overt GI bleed, like they may present with an hematemesis, they may present with melena, or they may present with an occult bleed. Patient will not know that is bleeding. So we'll only come to know if there is any, if you do any stool occult blood, then we'll know that he is losing a blood. So we don't surprise if the patient of carcinoma stomach presents with an anemia only. So here I repeat again, a patient who presents with an palpable abdominal mass without any signs and symptoms of obstruction or bleeding, probably one has to consider a mass which arises from the liver, pancreas, spleen, or retroperitoneum. So liver, benign liver lesions most of the times are asymptomatic. Even malignant also sometimes asymptomatic. Pancreas initially again pseudocyst, they may not have pain unless the patient had an acute pancreatitis 6 weeks back and now they present with a swelling in the epigastric region. A splenomegaly secondary to a portal hypertension or secondary to any hematological disorder, they may not have any symptoms except splenomegaly. Retroperitoneal lesions are masses notoriously asymptomatic. So we would like to always would like to know whether these anatomical basis. So on examination, you will classify whether this mass is arising from a stomach or a spleen or pancreas. We would like to know what is the cause of mass. The clinical course would like to know whether it's an acute, chronic, or it's an any urgent. So it could be a neoplastic lesion, benign malignant. In the malignant again, primary metastatic. Infectious sometimes, these are all mostly confined to uh, uh, liver or pancreatic lesion. Suppose liver mass, if you take benign masses, so cystic mass, as I said, most commonly, our area is an endemic for an hydrated cyst, or it could be a traumatic cyst also. Traumatic cyst, it means that patient must have had a trauma and blood hematoma, which after sometimes it dissolves and forms like a cyst, and it could be a hemangioma. These are all the common lesions, benign lesions seen in the liver. Hemangioma, adenoma, or focal nodular hyperplasia. Probably you all must have seen hemangioma, other things. Malignancy, hepatocellular carcinoma, and secondaries in the liver are the common lesions in the liver. So lesions that require intervention, it means it could be in a medical intervention, it could be in a surgical intervention, or any other interventions, or hydrated cyst, symptomatic hydrated cyst, mesenchymal tumors, adenoma, biliary cystoadenoma, hepatocellular carcinoma, cholangiocarcinoma, and metastasis. So in any liver lesion, so the clinical history again is most important. These are all the questions we need to find out. Does the patient have any symptoms? Number one. So age related, suppose elderly male, 70-year gentleman, presenting with a liver mass, one should suspect a malignancy because elderly people will have more malignant lesions. So is this patient is septic? Does he have any fever? Does he have any pain? It could be a hydrated cyst which is getting infected, or it could be an abscess in the liver. So this history also is important. Use of an oral contraceptives in the background of liver mass is important because we diagnose if there is a history of oral contraceptive, it could be a simple adenoma which occur in the liver. So risk factors for chronic liver disease like alcoholism or an hepatitis B, hepatitis C, over a period of time, these patients will develop a cirrhosis and malignancy in the background of chronic liver disease. So history of extrahepatic malignancy like colonic malignancy or in thyroid malignancy or breast malignancy, so that it could be sometimes a metastatic disease also. So evaluation of liver mass, initially we do all the liver tests followed by liver function test and then ultrasound. That's how we diagnose one by one. So Complete, if there is a less platelet count, it indicates probably a cirrhosis of the liver. And we also look for any viral markers like hepatitis B and C. Some of the tumor markers, we call them as tumor markers. If the tumor markers are elevated, say for example, alpha fetoprotein, if it is raised, so we consider most probably a hepatocellular carcinoma. However, it's not a 100% sensitivity and specificity, but sometimes yes. If CEA, tumor marker, raised, so it indicates that probably a metastasis from a colonic malignancy. And if CA19-9 raised, so we should also consider a pancreatic malignancy or an intrahepatic cholangiocarcinoma in these patients. So one important investigations, apart from the blood investigation, if you want to diagnose any liver mass, is the triple phase CT scan. So this is a triphase, we call it as a triphasic CT scan, which is usually done in arterial phase, venous phase, and in equilibrium phase. Just remember this. This is an high-tech. So arterial, so if we given a contrast, we'll take a picture in arterial phase and venous phase, and then equilibrium phase. So these are all the things. We know that liver has been divided into like this. Liver has been divided into various segments by imaginary line, which draws from the gallbladder to the inferior vena cava. So these are how coinard segments the liver. So suppose the lesion is arising from the segment 8, you can see that segment 8. So we consider this, okay, this is a segment 8 lesion, segment 4 lesion, like that. So you divide the liver into various segments and do a good triphasic CT scan and find out which lobe is involved or which segment of the liver is involved. So these are all the simple benign lesions like simple cyst, cystadenoma, hydrated cyst, amoebic liver abscess, hemangioma. Malignant lesions like cystic metastasis, sometimes they are cystic, very rare. So how do you evaluate this? So apart from the blood investigations, we do routinely ultrasound, which is easily available in all the hospitals, and which gives most of the times a very good picture about the cystic lesion. The ultrasound is done to differentiate between a cystic lesion and a solid lesion. That is very important. And again, we'd like to know which lobe of the liver is involved. So suppose, for example, on ultrasound, if there's a single cyst, if there are no multiple cysts, we consider it as a simple cyst, or it could be an unilocular hydrated cyst. If there are multiple daughter cysts, we might consider it as a hydrated cyst. That is how we diagnose the cystic lesion. If the patient has the history of a fever, history of pain, history of in the abdomen, history of on examination tender liver, it means that it's an amoebic or pyogenic liver abscess, amoebic liver abscess with secondary infection or pyogenic liver abscess. So similarly, we have other lesions in the body, in the liver, like a biliary cyst adenoma, that could be sometimes differential diagnosis. So if it is in a simple cyst, asymptomatic, very small cyst, you can observe, they may not need any intervention. Whereas a bigger cyst, which with symptoms, definitely they need an intervention. Sometimes we'll see a polycystic liver disease, which may not require any treatment unless it causes symptoms. So you can see the simple cysts are usually thin-walled, and if you see on a CT scan, it looks like this. You can see here the whole right lobe of the liver is replaced by a fluid-filled hypodense. We call it as an hypodense because if you see the left lobe of the liver and see this, the vascularity is less compared to left lobe of the liver. So a simple cyst here is this patient is symptomatic. So we operated and took out all the fluid and removed the entire cyst. This is a simple cyst. That is the commonest diagnosis of a cystic lesion in the liver. See this is a polycystic lesion. You can see multiple cystic lesions. The previous case, you are seeing a single lesion here, single cyst, whereas here you are able to see a multiple cyst. multiple cysts, and if the patient is symptomatic, this kind of patients might require a liver transplantation, or if one or two are symptomatic, you can deroof these lesions. This is an ultrasound picture of a polycystic liver. So hydrated cyst, our area is an endemic area. So hydrated cyst of the liver is very common. So history of contact with the pets is most important because man is an intermediate host. Definite host is an pig. So we need that kind of a history. Most of the times they are asymptomatic. If you do some serology, like serology, antibody serology, they might be positive. Imaging is very important. And sometimes as a part of the treatment, we aspirate the fluid as a part of the treatment, I'm telling you. So we aspirate and see the daughter brood capsules and scoliosis in the microscope. So we have various classification for that. Forget about this. So this is how the hydrated cyst looks like. See, there can be some confusion between a simple cyst and a hydrated cyst, but most of the times they'll have this kind of picture. It's called as a cartwheel sign or rosette appearance. You can see here. You can see the daughter's membranes floating membrane sign. So this is a septa. You can see that this is the classical of hydrated cyst. Any cyst with a septate, you should consider an hydrated cyst. And calcification. Calcification means most of the times it's a dead cyst. So we have various therapeutic options of hydrated cyst. We can treat these patients with a medication like an albendazole or praziquantel with an albendazole. One should be very careful because they have a toxicity. So or else best thing is put them on albendazole for a few weeks, then operate. Best thing is to remove entire cyst. It's called a cystopericystectomy or a de-roofing of the cyst. We have other methods where unusually done, not routinely done, as percutaneous methods. We don't do regularly. You can see here, this patient is an operative photograph of an hydrated cyst. You can see that all grapes like daughter cyst, small cyst, and with some bile stain, it has communication with biles. So we did a cyst excision with hepatico-jejunostomy because there was a biliary communication. This is a patient who had a high fever and CT scan which showed an abscess. So this is a typical of liver abscess. So there's no need to do any surgery. You can percutaneously ultrasound grade aspiration of these abscess is sufficient. Sometimes a malignancy of liver presents like this cystic lesion. You have to be very careful. They're all highly malignant tumors. So it sometimes as congenital lesions or congenital sometimes tumors arise from the liver could be in the early age. So this is a 4-year girl who had diarrhea. She didn't have any symptoms. She was investigated for that. So and found to have this kind of a cyst. See, this also looks a very big cyst. This is called as a mesenchymal tumor. So you can see this. We have named here segment 3, 2 is an umbilical fissure, and there's a tumor in the segment 5, 4, 5, and 8. So that part of the liver tumor has been removed. This is called as mesenchymal hematoma. Very rarely we see. So what are the solid lesions we see in the liver are hemangiomas and adenomas and other lesions. So if again, one of the important investigation is an ultrasound followed by CT scan. MRI has a definitely role in proving the diagnosis of solid lesions. So you can see here. So this is how hemangioma looks like. So entire liver is replaced by a cystic type of lesion, hypodense lesion. You can see a progressively delayed post-contrast image. Initially, there is no contrast, whereas as it progresses, entire mass is replaced by a white fluid. It's called a contrast. When you give a contrast, it slowly the hemangioma takes up the contrast. If you do an MRI, it's called as a light bulb sign. So in T2 weighted images, you can see that it looks like a bulb which is on. So it's called a light bulb sign. So this is a very giant hemangioma, which is occupying entire left lobe going up to the pelvis. So where we did excised. There are some other solid lesions like focal nodular hyperplasia. There are very rarely seen. The classically you see once you excise, you can see this scar in the center of the tumor. So that is uh, focal nodular hyperplasia. Adenomas, especially in ladies who had an oral contraceptives, they find this kind of a mass. So one should suspect adenoma of the liver. So these are all the common lesions in the liver: hemangioma, focal nodular hyperplasia, adenoma. So most commonly, they're all seen in female patients. These are all the ultrasound, CT scan, MRI, are the investigation of choice. This is an hepatocellular carcinoma occupying, can see the entire right lobe here occupied and which we removed. This is another neuroendocrine, big tumor from the pancreas to the liver. So, and sometimes we see a metastasis, most common lesion. The primary could be from the GI tract, lungs, breast carcinoma, or head and leg malignancy or lung malignancy. So this is how the metastasis look like. They're all multiple. You can see enhancement around surrounding the lesion. There are multiple lesions. If there are multiple lesions, solid lesions, you should consider a metastatic lesion. So you can see here the multiple lesions in both the lobes of the liver. So they usually come from liver, from the colon or from thyroid or from breast or some other lesions. So this is a child who had a very big tumor and can see such a embryonal rhabdomyosarcoma which occupying entire epigastrium and right epicondyle also. This is excised. Very rare tumors these are all. So history is very important, and investigations like an ultrasound and CT scan in any liver mass is an important to diagnose. If it goes to the pancreatic masses, most of the time, as said, pseudocyst. The cause for an pseudocyst is an acute pancreatitis. Patient will have an acute pancreatic episode of pain in the abdomen, conservatively managed, and after 6 weeks, they present with a cystic lesion. It's called a pseudocyst of the pancreas. Nothing but a fluid collection in the lesser sac without any epithelial layer. So just probably a rupture of a duct, pancreatic duct, and collects in the epigastric fluid collection in the lesser sac and forms a pseudocyst, which sometimes patients may have any symptoms, sometimes they may not have any symptoms. If the size is more than 6 centimeters, or if the duration is more than 6 weeks, which does not resolve. Most of the time they resolve, but 20 to 30% of the cases, they don't resolve. So we need to intervene by doing a surgery or by doing an endoscopic procedure. So best way of diagnosing all these things is again by doing an ultrasound or CT scan. So this is a pseudocyst of the pancreas in the tail lesion. See, this patient has an calcification. This is nothing but a chronic pancreatitis. So followed chronic pancreatitis and pseudocyst. One of the complications of the chronic pancreatitis is a pseudocyst of the pancreas, because repeated insult to the pancreas, there is a rupture of the pancreatic duct. The fluid come out of the pancreatic juice come out of the pancreatic duct and collects in one area. That's called as a pseudocyst of the pancreas. You can see here. So that's in a pseudocyst of the pancreas. So this patient needs surgery. That is in a pseudocyst. You can see that's in the stomach. So we are aspirating the fluid. You can confirm that. Into that kind of a fluid you'll see, and you are opening the pseudocyst. You can see a lot of pancreatic fluid juices come outside. So you can see that. So this is an infected pancreatic juice. So that's why you needed an intervention. So that whole thing is a cyst. and we need to drain. You can see that. So there is a big cavity there, and we need to do an internal drainage for this cyst. This is a young lady who had a big mass in the epigastric lesion, young lady, and this is a lesion coming from the pancreas. You can see, compared to the previous case and now, you find some solid element here. So it's nothing but a cystic neoplasm at the pancreas, wherein we did a Whipple's pancreaticoduodenectomy. You can see all these structures. You can see the portal vein here, and this is in a stump of the pancreas. This is in supramesenteric artery, and this is in a bile duct, and all these things. So we completely removed. So another lesion in the epigastrium is the carcinoma of the stomach. Any patient comes with a history of loss of weight, with history of vague abdominal pain, with a history of early satiety. Patient will complain, sir, I'm not able to eat. If I eat little, then that will be sufficient. So early satiety. So most of them will have a weight loss. 40% of them will have weight loss. They'll have a vague abdominal pain. Whereas in the early stages, patient may have just dyspeptic symptoms. If the tumor is in the gastroesophageal junction, patient might present with a dysphagia. So if the tumor is in the antrum or pyloric region, they might present with, as I said, nausea, vomiting. They may present with a gastric outlet obstruction with the typical visible peristalsis from left to right. We have another variety of a carcinoma stomach. It's called as rhinitis plastica, leather bottle. We call it as a leather bottle stomach, wherein entire stomach is involved. In that case, patient will complain early satiety, loss of weight, and loss of appetite. The best way of investigating these patients are, so they might even present with an anemia because, as I said, passing of the blood in the stools because the tumor bleeding. So they might have a melena, or they might have sometimes occult bleed. So best way of doing investigating is by doing an upper G endoscopy, biopsy of the lesion, and confirm that it's a malignancy, CT scan, and then do a surgery depending upon the site. So here in a patient, you can see such a huge mass, very big mass coming from the gastric wall. It's a stromal tumor. This patient, elderly male, presented with a massive GI bleed, hematemesis. Gastrointestinal tumors, they erode the mucosa and presents with a GI bleed. There's a big mass in the epigastric region and also in the left hypochondric region. You can see that extent of the lesion is going up to abdominal wall. So these are all stromal tumors. These stromal tumors arise from the wall of the stomach and the presence with a GI bleed. They may not have a pain, but they present with a GI bleed. You can see here quite a big tumor arising from the stomach. You can see here. So you can see the stomach. This is the stomach, and the whole thing is the tumor presented with a massive GI bleed. So it means that stromal tumors presents with a GI bleed, malignancy presents with an early satiety, loss of appetite, loss of weight, and epigastric mass. So we resected, we took out the lesion. You can see such a big tumor here that was excised. See here, this is the stomach wall and the tumor which is arising from the stomach. So it's called as a gastrointestinal stromal tumor. Let's see one case. Here is a 64 gentleman. So presented with chief complaints of pain in the upper abdomen since 1 month, early satiety since 1 month, epigastric fullness since 1 month. And he was all right 1 month back when he developed epigastric pain, which was burning type of, aggravated with food intake. So this patient has pain in the abdomen. He has pain is aggravated by taking food. He complained of early satiety. He complained of early epigastric fullness. He complained of loss of appetite. He complained of loss of weight, 11 kilos in 1 month. So he has all the symptoms suggestive of malignancy, particularly stomach cancer. So, but he has no history of GA bleed or vomiting or jaundice. He has no history of altered blood habits. And on examination, he did not have anything. His supraclavicular lymphadenopathy was not palpable. We should always look for a supraclavicular lymph node between the two heads of the sternocleidomastoid mastoid, because any GA malignancy like CA pancreas or CA stomach, sometimes colon reaches this lymph node. So this patient did not have any that kind of a thing. Abdomen was soft, there's no free fluid, and rectal examination, one should do always rectal examination and see whether there is any lesion in the Douglas pouch. So the best way of investigating or diagnosing his symptoms is by doing an endoscopy, upper gastrointestinal endoscopy. So what did we find on an endoscopy? We found an ulcer proliferative growth starting from the 30 centimeter. It means almost from the gastroesophageal junction into the fundus and the stomach. So body and antrum of the stomach and duodenum is normal. So it's nothing but a carcinoma at the G junction, which is extending into the body and the stomach. So biopsy was done, and which was suggestive of an adenocarcinoma. And then next, we need to find out whether this lesion can be operable or not by staging the cancer. That's the best way is to do it by doing a CT scan. You can see here, the stomach is grossly thickened, more than 1 centimeter. 1 centimeter, more than 1 centimeter thickness of the stomach wall indicates pathology. The differential diagnosis could be in a lymphoma, differential diagnosis could be in adenocarcinoma, differential diagnosis sometimes maybe eosinophilic gastritis. But this thickness, you can see the stomach wall, this is nothing but a lenitis plastica. So we did a total gastrectomy, and entire stomach has to be removed because it was extending into the body, and this patient is doing well. So thank you very much. It's now 5 to 8. So host, thank you very much for giving me this opportunity. Sridhar? Sridhar? Anybody from the host? There's one question. Is GA bleed a late symptom of a gastric cancer? Not necessarily, not necessarily. So he might have if there's an ulcer, it could be a benign or malignant ulcer. It can bleed slowly. Very rarely we see hematemesis in gastric cancer. We see hematemesis in a stromal tumor. Stromal tumors are different, and gastric adenocarcinoma is different. Sometimes we might see very rare massive GA bleed, but they can have a slow bleed. What is the prognosis of hepatocellular carcinoma? Well, it all depends upon the status of the liver. If it is in a cirrhosis, they may have a multifocal hepatocellular carcinoma. It means there may be more than one HCC. In that case, prognosis is bad. If it is in a single less than 5 centimeter confined to one segment, if you can excise, they'll have a better prognosis. It all depends upon what kind of histopathology is cholangiocarcinoma, hepatocellular carcinoma. Usually once you excise, size is small size, they may live for a long time. Background hepatitis is also important in these patients. If the AFP is very high, alpha fetoprotein is very high, they'll have a bad prognosis. It means that the tumor must have spread to other parts of the body. It's all supraclavicular lymph nodes is mainly because of lymphatic spread, retrograde lymphatic spread, and involved in supraclavicular lymph node. Nothing much. It indicates M1 disease, advanced disease, and one should not go ahead with in a surgery, we consider this as an M1 disease. It's called as a Trossius sign. Was there any significance of blood transfusion in the previous discussed case? Any malignancy, of course, if the hemoglobin is less than 8, we need to transfuse. So if in malignancy, and try to avoid giving a blood transfusion. If it is necessary, yes, we need to give. So significance of blood transfusion in the previous discussed case, yes, we gave because of hematemesis, we gave a blood. So and then perform a surgery. Sir, how does the management of stromal tumor differ from the adenocarcinoma? Very good question. This is a very good question. So these stromal tumor, if there are any complications like these patients bleed, we need to operate. We have no other option. And if the very big stromal tumors are very big and involving the surrounding structure, we may not operate. We do biopsy and confirm the diagnosis based on a special stains, and medications are available. Imatinib drug is available, and we give that drug for 2 years period or 6 months period, and then see the response. The chance that these tumors might respond to imatinib. So there is a medical line of management for a stromal tumor. Whereas adenocarcinoma, if it is an operable lesion, one should go ahead with a surgery. So there is a difference. Once the stromal tumors are completely excised, so we also see their mitotic index and size of the tumor, site of the tumor. All these things are important to prognosticate stromal tumor. Compared to adenocarcinoma, stromal tumors have better prognosis, whereas adenocarcinoma will have bad prognosis, especially linitis plastica or poorly differentiated adenocarcinoma. You may not do if there is a stromal tumor arising from the stomach, you may not do a radical surgery. Whereas in adenocarcinoma of the stomach, we need to do a radical surgery because of the involvement of the lymph nodes, lymphatics. So we need to remove all those station 1 to 12, we call it in gastric cancer. So we need to remove all these lymph nodes, and it's called as a radical surgery. Whereas that radicality is not necessary in a stromal tumor. Sir, should we also operate adenocarcinoma? Yes, of course, if it's operable. So there are no questions. Thank you very much. Thank you, everyone. I log out. Anyone? See that? Okay, thank you. Someone can speak? Any feedback? Samir, did you understood? I could see Samir Kumar, Maunika, Kirti Reddy. Okay, thank you.